So good morning. I'm here to introduce Dr. Kurtis Auguste, who is a pediatric neurosurgeon and director of the UCSF Pediatric Neurosurgery and Epilepsy Surgery Program, where he also earned his medical degree and completed his residency. His pediatric neurosurgery fellowship was out of Toronto at the Hospital for Sick Children. His research interests include epilepsy and neuronal migration disorders. Please help me welcome Dr. Auguste.
Thank you for joining me. I wanted to share with you some of the things that we're doing up at UCSF for kind of pushing the boundaries a bit and the envelope a little about how we use pictures and images to prepare ourselves for surgery, prepare our patients and families for surgery. And this is a story about virtual reality and augmented reality in brain surgery. So as mentioned, I direct the epilepsy surgery program, and so my job basically is to meet families and kids with epilepsy and seizures and figure out the best way to safely treat their problems. This is for patients who have a seizure disorder and those seizures are not being controlled by medication. That's always going to be our first line. But sometimes that is not enough and the medications aren't taking care of everything, and surgery needs to be considered, and that's where I come in. So the first step of this talk is going to be about virtual reality. And in order to really illustrate how it works, I need you just for the next 20, 30 minutes or so to pretend you are me, to pretend you're a brain surgeon. I'm officially giving you a virtual white coat right now. And so we're going to work through this together. You're in your office, you're meeting a family for the first time, and they're introducing you to our first patient, whose name is Jade. And Jade is 10 years old. And the thing about Jade is that she's a grade A student. She's the perfect child. So much so that mom introduced her and said, why couldn't this have happened to my son? He's the goofball, you know. And the son was actually with them, and it was shaking, yeah, I'm the goofball. Jade is the perfect grade A student, and what they've noticed though is that her school performance was declining, and that's not normal for Jade, and they knew something was wrong. And her test scores were slipping. And what they were noticing was that for about a year and a half, she would stop what she was doing and start to pick at things. And in our language, we would say that's behavioral arrest. Whatever she was doing would stop. And this would go on for initially 30 seconds, then 2 minutes, then 5 and 10 minutes. And it was first noted at school, and then they started noticing at home, and then it was time to see a physician. She was eventually diagnosed with seizure disorder, and that started a long journey of figuring out where the seizures were coming from. So she started on medications, by the way. The medications weren't controlling things. She had an EEG, and an EEG, for those of you who aren't fully aware, I'm sure this audience is aware, but it's an electrical test, basically. It's looking for where the electrical abnormalities are in the brain that might be causing a seizure. And then she did actually end up getting a scan of her brain, and it showed this. Now, this is not going to be so easy to see, and that's kind of my point. I'm going to highlight for you that in the back of her brain is a fuzzy area. It's a blurry area. And what it was a tumor, and it was deep in the center of her brain, and it was surrounded by normal anatomy. But here's the problem with Jade's tumor, and this highlighter doesn't really show it, but it's actually right here. And it's not that easy to see what's normal and what's abnormal. But what the problem here is that it's deep. It's surrounded by these white fibers, which in Jade are her optic radiations. Her ability to see is transmitted through these white fibers. I've gone ahead and highlighted where the tumor is in case it's not so obvious. So optic radiations, tumor. Nearby also, not just her vision fibers, but her speech fibers are nearby. And so they're blocking certain pathways down to this thing. The other thing is that it's not just about functional tissue that's in the way, it's about anatomy. So you know your brain is covered in blood vessels that bring rich blood to the brain and then take away old blood from the brain, so arteries and veins. And in Jade's case, the vein of Labbe and the place where that vein plugs into the base of the skull, the transverse sigmoid junction, again, are in the way. Okay, so remember where that tumor was. These arrows are kind of in that same vicinity. So if you are now at your desk and trying to figure out how am I going to help this child, these are the things that you got to worry about. Okay, so how are we going to do this? We're going to come from the front because we can't go through the transverse sigmoid junction. We can't go through that big vein. But are we going to lift up the brain and go from the front, or are we going to go from behind? Why does this matter? If we go from behind, she has to actually be on her belly. She's going to be upside down. Now, that's always a little bit dicey because our anesthesiologists have to control Jade's airway with a breathing tube, and if there's ever any glitches or issues with her breathing during surgery, she'll be upside down, covered in drapes. This is a problem. So we do this all the time, by the way. It's just that we don't take these decisions lightly. So here you are trying to decide, am I going to come from the front? Am I going to come from behind? Here are all your concerns. And basically the exercise that you and I are just doing right now is what you do as a brain surgeon every day. You take all these slices of flat images, and in your mind's eye, you recreate a three-dimensional object with the hope of safely creating a surgical plan. So this is a challenge, and you spend your whole career getting better at this. And when you're a medical student and a resident, you don't really fully understand this anatomy. I'll tell you a secret. Even as a full-on surgeon, some of these little details are difficult to really figure out in your mind's eye from these 2D images. And even though you become an expert at it over the course of your career, we're still human, and we're still subject to these little errors that might be processing from 2D to 3D. So why can't we use technology to help us? So that's partly where virtual reality comes in. So now we're going to take all these 2D slices, which are black and white, and it has some of this anatomy built in, the optic radiations in the veins, and we're going to three-dimensionalize it. Okay, so now this is what it will look like in virtual reality. So immediately you'll notice a difference. So gone are the black and white and grayscale images. Now we have color, and we've chosen what colors to use. So the blood vessels are going to be in bright blue. The tumor is going to be bright red, and those optic radiations I told you about, they're these green spaghetti strings that are draped over the tumor. So there are going to be a lot of different relationships, three-dimensional relationships that are going to pop out at you in 3D that are kind of bland and really hard to see in 2D. So we're going to start this video here. We're going to take a fly through Jade's brain. We're coming from the front here, and you can see that the optic radiations are above us. Here are all those little blue vessels that might be in the way, and some of those vessels that were on the surface of the tumor are much more obvious in 3D than they were in 2D. It's a little bit of a constrained window as you're coming from the front, and the vein of Levay is bumping right in the front there. So let's go around this vein of Levay now. Instead of coming from the front, we're going to come from behind and see what that view was like. And so when you compare the two views, there's actually a lot more breathing room behind the vein of Levay than in front of the vein of Levay. And actually, we chose to come from behind on Jade's tumor to get much easier access to the tumor. Also, when you come from behind, her optic radiations sweep up. If you come from the front, the optic radiations are down in your face. So these are all little relationships and details that don't come out on that old MRI that are really popping in 3D. But it's not just about making these pretty three-dimensional models. It's about actually being immersed in the anatomy. And in order to explain how this journey really unfolded for our practice, I need to take you to Christmas 5 years ago when I was taking my nieces shopping. And I promised them to go to, I think it was Justice, or I forget what store it was. But we got to the cashier, and the cashier said, "Congratulations, sir, for spending $300 on jeans. You get this," and she gave me this box. And inside the box was a virtual reality headset. It wasn't, all the bells and whistles kind of headset. All it was is really a little box that you slide your phone in. But you guys all know that our phones are positionally sensitive. So when you slide this thing into the box and you move your head around, it becomes a VR goggle, basically. So here I was spending $300 on jeans, and I'm holding this VR headset. And it dawned on me, this technology is weaving its way into our lives in all these different ways. You know that you probably are aware that virtual reality goggles are now commonplace. You can buy them on Amazon. You can play video games with them. You can basically take tours of places you've never traveled to. You could shop a car. You could try on clothing using virtual reality goggles now. And so here I was thinking, wow, this is really cool, but why is this technology helping me play video games and shop clothing and not helping me in the operating room, in a place that I really could use three-dimensional help? And it was time to really push the boundaries on what we're doing. So I'm not just now using VR to shop. I'm using VR to prepare for surgery. So this is, these are headsets that you can put on, which, by the way, are in the back of the room. I want you all guys to try it when we're done here. We can put the headsets on and use hand controllers to move the anatomy basically what you're doing is you're shrinking yourself down to the size of a mosquito, and you're flying around this anatomy. But it gives you an opportunity to be immersed in this environment and see these details, up close and personal. But it also is an opportunity to rehearse different approaches to your job. If you're going to do surgery, why not practice ahead of time in full scale but in virtual reality, so you never hurt a patient? And this is done days or weeks ahead of time. By the time we get to the operating room, we're all set. We don't have to do trial and error there on site. So this is, again, this is Jade's anatomy, and I just highlighted some very important blood vessels that we have to be aware of when we're studying the 3D model. And it turns out, and I apologize, I should have warned you, I'm going to show a couple brain images here and there. But I did point out that some of those blood vessels that showed up on the 3D model are very obvious and apparent when you come under the microscope. And the fidelity, meaning how real were the 3D models compared to the real anatomy, the fidelity of VR to the real world microscope was actually incredibly high. Everything I thought was going to be in a certain place was in a certain place. And so this is just an example of those pretty, little blue streaks on that red model. This is what they look like in real life. It's not easy. It's still not easy, but any tool that you can use to make this job easier is going to be helpful. And then it turns out the blood vessels that I was watching on the 3D model were coursing through the tumor. They weren't just feeding the tumor. So if you were kind of rash and quickly took the blood vessel away, you would have starved any brain and caused a stroke that blood vessel was feeding. And in this case, right above us, if you remember those spaghetti strings, were Jade's optic radiations. So if you took her optic radiations, Jade would be blind on one side of the world. So this was a case where the anatomy really was helpful to know ahead of time and be prepared for these little landmines. And at the end of the surgery, Jade's vision was perfect. So this is just on the left is the pre-op images of Jade's tumor, and on the right is the post-op where the tumor's gone, seizure-free, tumor gone. This is nice when you have a case where there's an object or a target that is the cause of a patient's epilepsy. But many times our kids' epilepsy is not caused by a tumor or a mass or a lesion. Sometimes you have, and more often than not, you have just a regular looking MRI with nothing obvious. This is actually more typical, not like a Jade story. So what do you do for this case? So again, this audience is probably well versed in how we answer the question of where are the seizures coming from? If you're asking us, surgeons, neurosurgeons, to figure out how to go get the source of the seizures, well, our question is going to be, well, where are the seizures coming from? So when I first started at UCSF, it was like 15 years ago, the way we would do this is we would open the head, make a big window, it's called craniotomy, and we would lay sheets of electrodes over the surface, or we would slide strips of electrodes around the bends. Sometimes we would actually place depth electrodes, little fine electrodes into the tissue itself, but it was largely these bigger procedures with these grids and strips. So replacing that now in a sweeping way the past 5 to 10 years has been this technique called stereo EEG, where you use a coordinate system basically to look at anatomy in 3 dimensions and have areas of interest. Basically what this is, though, is a fancy way of casting a net and releasing microphones, basically, to listen for seizures. So instead of doing big craniotomies now, what we're doing is we're making little nicks in the skin and floating little electrodes down into the brain tissue to study the brain in 3 dimensions. So no big incisions anymore, just little nicks in the skin. But it's very coordinate driven. It's a very precise 3-dimensional kind of GPS for brain surgery type of exercise. So stereo EEG. So what is it? So these are fine little depth electrodes. We make a little nick in the skin and through the skull. These are called twist drill holes. It's much less painful because you're not making big incisions anymore. You're making little nicks in the skin. And because there's less pain, and then because there's much smaller nicks in the skin, the recovery is much faster. It does require a game plan ahead of time, a localization hypothesis. You kind of have to have a sense of where these things are coming. Instead of just the whole brain, it should be a lobe, or at most 2 lobes, or 3 lobes, but not the whole brain. So you have to have a hypothesis. This does allow you access to deeper structures. Those grids and strips are on the surface, the ones I told you about before, but these can go into the actual anatomy. But you got to find a safe path down, through, and in between the blood vessels to not cause any harm. This allows us a 3-dimensional access to the tissue. It allows us access to multiple lobes at the same time. Usually we use frames to get that GPS coordinate system down, but sometimes we have frame-less techniques as well. Much lower risk of hemorrhage than the bigger surgeries, obviously. And we use a lot of preoperative pictures called angiography to look at the blood blood vessels. But this is just a quick primer on this technique, so stereo EEG. This is kind of what it looks like on the imaging. Back to the imaging. This is a two-dimensional slice of a brain, and here are these little depth electrodes going into our targets. This is the planning ahead of time that you're doing in your office. But if you look at this image on the left, it makes it look like all these electrodes are on one slice of the brain. They're not. This is just one slice, but we can't tell depth-wise how far, how high, how low. So let's make a 3D model. Here it is on the right. This still is a 3D model, though, on a 2D platform. So we're looking at this model on a flat screen. But it's a little bit better. Now we're sort of threading the needle between those big red motor fibers and the yellow optic fibers, the vision fibers. So we're threading our needles, among all this really important anatomy. So 3D is still better, but if it's still on a screen, you're not rehearsing surgery. You're not seeing what you're going to see at the end of the day of the procedure. So now this is the standard of care before virtual reality, and this is how we would register a patient during the operating room. We would use this GPS system with a pointer, and it would show me all the places on the patient's head where I'm going to enter. I would shave a little bit of hair, and then when we're done, there are these little bolts that hold everything in place. But little nicks in the scalp now, no big incisions. So this is how it would look in planning for 2D, but let's bring virtual reality into the mix now. We're going to fly through this patient's anatomy like a mosquito, and we're going to look for any electrodes that might get really close to blood vessels. So you're going to go ahead and you're looking through this anatomy, and you see how this red electrode is coming down, and it sort of tags a blood vessel right there. So that's an electrode that you're going to want to change the trajectory on and adjust on the fly. But this system lets you, while you're actually virtually standing in this patient's brain, take one end of the electrode, take the other end of the electrode, and kind of maneuver it while you're in the patient's brain to make sure you're not tagging blood vessels on the way. In a 2D world, the way you would do this is you actually have to go through every flat slice and travel down the whole path. And on the way, you may say, oops, I'm hitting a vessel, so that means I have to change my target or I have to change my entry. Let me move it, and you do it again. Oops, that little move now bumps me into a different vessel. Oops, over and over and over. And if you're doing 12, 24 electrodes, that is incredibly time consuming. Versus this system where you're actually in the anatomy and you're maneuvering as you fly, it just takes seconds. The time it took me to describe is the time it takes to adjust the electrode. So this is how virtual reality is spilling into our world for epilepsy surgery. Yeah. Correct. It's the latter. It's newer. This is out kind of outside the box. This is not available everywhere. We are all beasts of habit. If you and I are brain surgeons and we do something safely 1,000,000 times, we're going to feel comfortable doing it the old way 1,000,000 times and know what the outcomes will be. If you've lived a career like that and newer technology comes along, and I'm asking you now to get outside your comfort zone and try something that you've never tried before, the outcomes aren't well known, it's a leap of faith. So that's why sometimes innovation, new technology, is slow to take hold, and some of us who are beasts of habit, it's harder for us to adapt to changes, and sometimes it's hard for the old dogs to learn new tricks. So you have to have the right mindset and do your homework, obviously, and make sure you're keeping people safe and patients safe. But this is how you push the envelope. This is how you change the game. This is how you get better outcomes and make things safer. You do have to up front take a leap of faith. So it's not widely available because many of us are just so used to doing it the usual way. It's not widespread yet. So you're going to have to imagine you are a mosquito for these next couple of images here. You, the mosquito, neurosurgeon, by the way, are actually inside this patient's brain right now. These two panels, A and B. So you are looking at the very bottom of an electrode, the pink electrode, that's covered in a blue sleeve. You are looking up through the brain from the bottom up. And what you can see in the distance are these giant pipes. Those are the blood vessels on the surface of the brain, and also some pipes on the way down. So basically what you've already done now is you've flown down to your target and looked back up through the canopy of blood vessels to see, is this a safe path for these electrodes? So this is just an example of one of the electrodes. And then I'm going to fast forward to, okay, well now we already had the electrodes in, we found out where this patient's seizures were coming from. In this case, it was coming from this patient's orange sausage-shaped structure called the cingulate gyrus. And if we know that the seizure is just coming from the cingulate gyrus and it's really deep, well, we could design a brain surgery where we open up the head and go and put our hands in there and our instruments in there. Or instead, we can do something called laser ablation, where we actually float a wire down through the barrel of the sausage. But herein, this anatomy is one extra tool. If you're in the brain looking at this 3D anatomy from within, you can start to plan, well, how am I going to get that laser wire to the destination down the middle of the sausage? So that yellow line on the right screen is already a plan for a laser wire to come down the sausage-shaped cingulate gyrus in this patient to cure this patient's epilepsy. So laser ablation is another new technique that I'll mention as part of this augmented and virtual reality talk. Laser ablation, why is that helpful? This is a great example of a patient who needs something that's minimally invasive. This patient is 8 years old and has had laughing spells 20, 30 times a day, little giggles, and they thought that he was just misbehaving in class, but what it was these were special kinds of seizures called gelastic seizures. They're giggle episodes. That lesion, as you saw, is really deep. Here it is. Here, I'm going to kind of highlight a little bit if I can. In the center of the brain, that kind of bland white, my arrow is on it right now. That's it's called a lesion called a hamartoma. It's coming off a structure in the brain called the hypothalamus. So hypothalamic hamartomas are notorious for causing these seizures called gelastic seizures. This patient, like many of my patients, have failed multiple medications, and he never had a day where he had less than 20 seizures a day. So devastating. Quality of life, family, patient. But that's a deep-seated lesion. It's not easy to get to, and brain surgery, as you get deeper and deeper, is more and more dangerous. So insert now this technique called laser ablation, where you can float a wire down to deep structures safely with the same GPS strategy we just talked about. And at the end of the wire is a little laser. You turn on the laser and it melts the hamartoma from within. Again, through a little nick in the scalp. No big incision, no moving aside normal anatomy to get to the deep. But laser ablation is one of the new techniques that we have as well. To do it, you place a frame on the patient's head and you get a scan, and with the frame on the pictures, you generate your GPS coordinates. And this is an entirely coordinate-based exercise, just like the stereo EEG electrodes I mentioned to you before. So a little twist drill in the skull, float the laser down, you ablate, and in the MRI scanner, you can see the tissue heat up and estimate how much tissue is being ablated and removed, and then you remove the head frame after you get a scan. So this is the kind of bolt that you end up having. Again, you'll notice the difference. No big scar, no big incision. It's just a little. Sometimes we don't even shave the skin, shave the hair on the skin. We just clean the skin, place the little bolt, and through the bolt is where the wire goes through. This is a scan, an MRI scan with the wire in place, and as you can see, it's floated all the way down to the center of the hamartoma. And now we can assign thermal safeguards. I don't want to hurt anything important, so I'm going to have this machine shut off if these little red X's detect a temperature higher than I want in something I care about. Meanwhile, in the center of those X's, it's going to go to work. It's going to go to town and melt this hamartoma. And as I mentioned, you can measure the temperature of things in real time. This is a video sped up. The blue pictures are the temperature, and the gray and orange pictures are the ablation. We're estimating how much tissue we're ablating. Again, no big incision, just a little nick in the scalp, all GPS driven. So laser ablation has been a huge addition to our strategy. This is the MRI afterwards, and the hamartoma is melted. This is an example of how now we're using virtual reality, though, for that technique. So we've plotted a course, and this is the way it would look on the two MRI scans. It's flat, it's grayscale. It's a little bit hard to appreciate that white arrow is showing us where there's a blood vessel. That little white dot right there is a blood vessel. And this trajectory that we're planning to get down to the hamartoma is passing awfully close to that blood vessel. That makes me very, very nervous. But this is the level of detail you'll get with a 2D slice, and this is the level of detail that you'll get with virtual reality. So now the C panel is us, a mosquito, down right next to the hamartoma, and we're seeing where that trajectory is with respect to this blood vessel here. So here it is here, and here's another blood vessel that we didn't even see on the MRI, and we're getting a sense of how can I wiggle this laser in place using my hand controllers there to safely avoid those blood vessels. The D view is now we're beyond the hamartoma, looking back over our shoulder, looking up at the sky to see the whole path of this laser coming down, avoiding, dancing around all these blood vessels in 3D. And if I'm not happy and I don't have enough of a buffer or a wiggle room, I'm going to move it on the fly, and it takes me just seconds. Okay, so this is a quick fly through of, let's see how we're doing on time here, good. You being the mosquito, coming from the top of the patient's head, you've generated a little pretend corridor, and the blue down deep is your target tissue. It's where the hamartoma is kissing against the surface of the brain. If you can melt that kissing surface, you've disconnected the hamartoma, which is orange, and no gelastic seizures can be generated through this hamartoma anymore. So you're flying around, checking the anatomy, double checking, triple checking that you're happy. I've even gone ahead and planned 2 trajectories just in case I'm not happy that we've got the whole surface. It's a really nice, reassuring way to know that you've got what you want. So that's how, just little samplings of how virtual reality has been helping, but you can see in the operating room how virtual reality has its limitations. Here I am in the OR. I got my patient off to the right in the bottom there, and I'm flying the anatomy before the surgery with these headsets on. If I'm operating and I have a question, I can look to my left and see these virtual reality images, but that's a problem. I don't ever want to take my attention away from my surgical site if I can. So looking and turning is not ideal. So virtual reality was never going to be the final answer. It was super helpful, but the goal hasn't always been virtual reality. It's something different. It's augmented reality. I would rather have these holograms on the patient's actual anatomy instead of having to turn my attention away from the brain, stop operating, and keep going back and forth. So augmented reality is taking this virtual world and blending it with the real world, but being registered so that those holograms don't move. Okay? So let's show an example of how this is helpful. Again, let's use a patient. This is one of my patients who presented with seizures who had this lesion in his temporal lobe called the it looks like a little popcorn. It looks like a little popcorn kernel there. That's a little blood vessel abnormality called a cavernous malformation. It was bleeding in the past. That's why it has that black rim around it. And it's that irritating blood product that causes the seizures in a CAV-mal patient usually. So this patient's been seizing, has this lesion. We have to go get it. But if you remember in Jade's case, her speech cortex was nearby when it's on the left side of the brain. And same was the case for this patient. This patient's speech cortex is nearby. You don't want to hurt that. So we have to find a way to navigate safely in the brain. So looking at the brain under the microscope when you first expose it, I don't know if you can, I know you are now neurosurgeons, but I don't know if you can tell me where this patient's cavernous malformation is just looking at the surface of the brain. I have a sense because this is what I do and I've studied the MRIs, but you don't know exactly where that CAV-mal is. You also don't know exactly where this patient's speech cortex is. I want to help him by getting the CAV-mal out. I don't want to hurt him by damaging the speech cortex on the way in. So this is a challenge. Where is a safe way into this patient's brain? So it's just imaging of the brain pulsating. It's a moving target of sorts. Now we're going to bring in virtual reality images. And we're going to recreate this patient's anatomy where the purple and red inside of it is the CAV-mal. The purple is that rim of bleeding. The red inside is the CAV-mal. We're going to place an ideal point of entry, a yellow dot on the surface of it. We're also going to get a sense of where's this patient's speech cortex. So we've colored it in green, and it's floating above your target. And then the last blue thing is a structure called the ventricle, where the fluid, the spinal fluid, is in the deep part of the brain. If you are in the ventricle and you see spinal fluid, you know you're too deep. So that's just a kind of a safeguard. So now this hologram is generated. You can fly it with your headset in your office. You can even turn during the surgery and look at it. But like I said, wouldn't it be so much better if I didn't have to turn and keep looking and I can look at the brain and see it in real time? So this is now the view you had before, the hologram in VR, and the two worlds are going to blend together when you press a button. So now, effectively, I've just given you X-ray vision. And this X-ray vision is locked. So you can move your head in the microscope all around, but this anatomy is going to stay exactly where you wanted it to stay. And I will always know now where this patient's CAV-mal is. I will always know now where his speech cortex is, and I'm going to help him without hurting him as best I can. So the technology is even better than that. It's got a little bit of I call it kind of like a Goldilocks effect, where it can tell you how hot or how cold you are. You're getting warmer, getting hotter, and it'll also give you a measurement about how off you are. Let's say you're pivoted too far to the right. This will give you a measurement of how far off to the right are you, and as you're moving, that number is going to get smaller and smaller and smaller. It's like real time. You're getting warmer. You're getting warmer. So let's just give you a sense of things. Here's your yellow dot, your ideal entry. You can see it on the surface of the brain. I'm going to go ahead and get this surgery started. This corridor here is going to be the safe spot. The speech cortex is buried and protected. We don't want to touch it, so I've covered it up. I'm making a safe entry here. I know it's safe because I can see good and I can see bad. So we're going to get this corridor started. But as you might notice, we're a little bit off to the side, a little bit to the left. Let me move the microscope a little bit and really get that yellow dot a little bit better underneath our entry. It's a little bit hard to see here, but it's right here now. And see how you've been able to line up your corridor with the sweet spot. So we're going to keep working and getting a little bit deeper. Now we're actually into the patient's brain doing the brain surgery. We're starting to remove the cavernous. You'll notice the green is gone and we're starting to see the cavernous being sliced. That's because your focus is now in the depth of the cavernous. This shows you how deep you are and how much more cavernous has to go. I don't know if you can really appreciate it looking at it in the microscope. I can't. As you're burrowing through tissue, you always have this thought, how much more do I have to go? How much deeper does this go? Well, you can't always see in the microscope, but when you have this kind of technology to show you how deep you are, it takes a lot of the guesswork out. It keeps you safe. All right, so this is the view you get, which is not very helpful. And you're trying not to open a wide corridor to hurt this patient's brain. You want to work through the smallest possible entry, but it limits your view. This is the Goldilocks effect I told you about. So this blue crosshair is where you're staring. The yellow is your sweet spot. The dotted line in between is the adjustment to get you there. And then this number, 7.7 millimeters, is how much of a deviation you are from your sweet spot. So as you're operating, you're moving and you're changing this number. And then this green line here is just showing you where you're looking compared to your sweet spot. And then this patient did great. Cedar's gone, cavernous out. So in the few minutes that remain, I showed you what virtual reality is helping us do our job as neurosurgeons. I showed you what augmented reality is now offering. There was a little bit of an unexpected twist to this story as a pediatric subspecialist, though. Okay, so here I am introducing this technology for the first time to my patient. This is actually Jade. She's seeing her tumor for the first time using headsets. And mind you, this is 2 days before her brain surgery. So they walk into the room and you can tell, mom, dad, in their faces, you can just, the tension in the room was high, and you can tell how worried they were and how the sleepless nights that have led up to this. And it's 2 days before brain surgery, they're petrified. So Jade is sitting in her chair, and I'm taking her through a tour of her brain. In the midst of all this, she reaches up and tries to grab her tumor. Okay? So then she starts to laugh, and her brother starts to laugh. And then her mom and dad just bust out laughing, and it was like the way the world was starting to lift off this poor family in this one moment, like to cut through the tension immediately. And I realized this is something really powerful. This is 2 days before brain surgery, and I had this little girl seeing the cause of her seizures, reaching out and trying to grab it herself, kind of effectively empowering her to go get this problem herself. Giggling 2 days before. I know I'm not going to be giggling 2 days before my brain surgery, and yet this kid was. And then the mom and the dad knowing that their baby's going to be okay because she's got this. She's laughing, she's giggling, she's reaching. It was such a powerful tool to me that I realized here I was, this adult, thinking I was sharing this cool world with these kids. It's completely the opposite. It is me being a guest in their world. Many of you probably have these headsets on a coffee table, or your kids want them on their coffee table, and they're playing in this virtual world, and we are learning from them how to exist in this place. Suspending your disbelief and pretending you're a mosquito and flying around like a video game, this is what kids are doing nonstop all day long. When you're a doctor and you're trying to make a connection with your patient, it's gold. it's really hard when you're a pediatric subspecialist because we come in with a white coat and it's very intimidating. Think about all the times that a surgeon is explaining a brain surgery to a family and the kid's in the room and all these grown-ups are talking as if the kid's not even there. How tragic is that when the most important person in the room is not even involved in the conversation of what's going on and what's going to happen? And this is the way in. This has been a way for us to connect and relate to what the problem is. Okay, so I had a lot of questions about this. I was like, this is crazy. Where can we go with this? Are the kids going to have fun? And can they learn how to actually navigate all this equipment? So this is a headset that actually has a special camera on the front that watches gesture controls. So it's not just these special joysticks that they can use now. They can actually use their own hands. And this 7-year-old is able to use his hand to grab Jade's tumor and play with it and measure and do measurements just like he's performing surgery. How young can you go? Well, this is the youngest patient. He's 3.5, 4 years, almost 4 years old. A 4-year-old is going to get something very different from the experience than a 14-year-old, but they're still getting something out of the experience. They're not sitting in a chair being talked over and not being included in this very important experience. And the funny thing is I actually had once had a dad come to me and say, Dr. Auguste, thank God, I'm so happy today. We had our clinic visit. He won't stop asking me, when are we going to go see Dr. Auguste again? And so what neurosurgeon doesn't want to hear that? And what kid wants to go see their brain surgeon? And this technology made that happen. I had another parent come up to me and say, I'm really glad you have this now. I'm 55, and I still have nightmares about when I had my tonsils taken out as a 5-year-old. I just wish this technology was available, when I was a little girl preparing for my surgery. And it was heartbreaking to think, here's this person who for 50 years has been harboring these nightmares about this really scary experience, and they had no way to make it more relatable. And just for a second, I'm going to get off my VR and AR soapbox and just talk about medicine in general. If you're a child and you have a frightening experience as a child and you lived your life fearing medicine, or you're a child and you had an experience where you were able to engage with something with this cool, playful technology, and you had a really positive experience, which of these two kids is going to grow up to be an adult who takes their medicine, makes their doctor's appointments, maybe doesn't make an excuse to miss a doctor's appointment? Oh, I'm so busy, maybe I'll call the doctor. It's just a little pain in my hip. It can't be anything serious. Which of these two patients is going to do better in their lifetime and be better patients? And which of these two patients are we going to want as physicians to take care of? How easy is it going to be? So that's how important stuff like this can be. It's not just about the pretty pictures. Real quick, I know we're going to run out of time soon. I want you guys to fly. This is the next iteration of how far can we take this? I can fly by myself. I can put the headset on the kids. Can we all put the headsets on and be in this world together? And so this is something we do up at UCSF, is where we share the experience together. So on the left, you'll see there are little avatars of our bodies with our names above them. So every one of us has a headset, and our names are floating above our heads. And so when you look in these headsets, the left and right, you'll see mom, you'll see dad, and each of us has the ability to fly, and we have this joystick. So I am giving a tour.
Mom and dad see me? We're going all the
hear
way
my voice here. I'm
inside
navigating,
Jade's
talking
brain.
them through this
Tell me when you
anatomy.
get there.
I'm showing them interesting things. I'm showing them how I'm going to do the surgery. Okay. I'm showing them the vessels that I care about.
So, if you can actually fly past, hey Dad, if you can actually fly past me, or get yourselves on either side of me so that I'm not blocking you. There's something I want to show you. Even more. I'm going to go away a little bit.
At the end of it, I release them.
Okay, and then Dad, can you look over your right shoulder? Like all the way behind you? Keep going. Can you see this arrow that I'm pointing up, all you guys? Because I'm pointing the tumor. But
so this is a much richer experience where the family can do it together. Next question I had was, well, yeah, it's all cool and sexy technology, but are we making a difference in how these kids are understanding their pathology? So I took this patient, he's 12, he had an AVM, an arterial venous malformation that caused his seizures. And I'm taking him through a tour of his anatomy, and then I put the headset on him, and I said, let me see how much he's retaining, and I'm going to quiz him. So I started asking him questions.
Point to your AVM now. There it is. And then can you point to that vessel that was feeding the AVM? There it is.
So a couple things, and I'm sorry for our remote participants who won't hear it, but I was asking him to point out important anatomy, and he was nailing it every time. But it wasn't just that. I don't know if you can hear it, I'm sure my listening audience can't, but in the background, I don't know if you heard those extra voices that were piping up every time I asked a question. What it was his 6-year-old brother and his mother, whose language is English is a second language, who were fighting with each other to answer the question that I was asking the patient. So I was laser focused on this 12-year-old to teach him about his AVM and teach him about his anatomy, and I wasn't even realizing that that's how powerful this experience was. Even though I didn't even intend it, I was the 6-year-old was learning, that the mom was learning, the mom who barely spoke English was learning. And so you've heard the phrase of, a picture's worth 1,000 words. This is a perfect example of that to make this an easier explanation of what's going on. And again, isn't this what we want as neurosurgeons, to teach these kids about their own anatomy and teach them what's going on and understand? This is a home run music experience. So that was just a quick, whirlwind tour. I'm under time here, of how we're using these holograms to prepare and rehearse for surgery, how we're bringing it actually to the actual surgical field, and giving you x-ray vision to keep these patients safe. But even better than that, we're enriching this experience for the kids and the families to be engaged. And they get to take it home with them. When they're done with me, I send them these fly-through videos. And so if Uncle Joe and Grandma Sally couldn't make the visit, they can fly through this anatomy at home. And I actually have boxes that I can send my families that they can put their phones in and use as VR headsets. It's not quite the same experience. It's kind of like the Pirates of the Caribbean ride. So I pre-format the ride, but when you have the VR goggles on, you can at least look around and check out the pirates and the drunken sailor off to the side, and we'll keep it moving. So that's all I had as a presentation. I'm happy to take on any questions, but very, very important, when we're all done here, if your time permits, we actually have Jade's case set up in that VR headset, and I would love for each of you, if you have time, to fly through the anatomy, just as if you were preparing for surgery, and see some of those same blood vessels I talked about in my talk, and get a sense. And one last request is, once you've actually shrunken down and you've gotten to mosquito size and you've actually gotten up close and personal to the tumor, I want you to stop, and I literally want you to look. It's going to feel silly, but I want you to look around, because you have to understand that your head now is a joystick, and that's the only way you can fully appreciate that you are now immersed in this patient's brain. Okay, so please remember to do that when you do fly this anatomy. So thank you. Questions? Yeah. Sure. Go ahead.
Do you know of other hospitals in California that are doing this? Any of the Southern California hospitals, CHOP or UCSF?
Yeah, I know the technology is available. To what extent they use it, and are they using it just for VR? Are they putting the headsets on kids? Are they doing shared experiences? Are they using augmented reality? I can't speak to that. It's something you'd basically have to ask each individual practice. But I do know that some other children's hospitals, not just in California, across the country, have it. I can only tell you about our program. I don't have the specifics of it.
I used to live up north, and I really miss UCSF a lot.
Yeah.
And then we went to CUA, and they couldn't even see the things that you guys can see with the technology. Well, we don't see the lesion. We don't see the tumor that you guys wanted us to keep track of.
Yeah.
They finally said, well, because our magnets, we don't have as many magnets, or they're not
All right. Strong.
Like
Yeah.
that, so we don't have the same imaging.
Yeah.
So we moved to UCLA, but I still just really miss you guys.
We miss you too. But it's I hope that as the pace of innovation ticks along, we all catch up. It's not just about UCSF, taking off. This is the way we should all be communicating, to each other.
Family inclusive.
Yeah.
I felt like you guys really listened to the families, we were included in the whole.
It's it's key. We wear the white coats, but the decisions we have to make together.
What did you think would be some of the biggest obstacles for adopting something like this technology?
Well, I'm standing here. This person here, I think, is key, because as a family, you don't know what is available in terms of tech or innovation, and you don't know what's safe and what's not, or what's bogus. or bandwagon stuff that people are just jumping on versus this is actually meaningful. It's not up to you, it's up to us. That's number one. We are screening through all this sea of stuff and helping you figure out what's best for your child. That's number one. Number two is we got to share it. I have to take the extra 10, 15 minutes in a clinic day and set up the room, and fly you through. It's much quicker for me to just point on a black and white screen and say, see the tumor? Good. Anyway, can you sign on this? It's, again, heartbreaking that is about like how 95% of in these appointments will go because, it's not always, but if it's important enough, you make the time, and so I do think that a lot of it comes to this piece of the puzzle, not you guys, it's us.
Two quick questions. One is who came up with like the technology to do this, and who's the maker, I guess, of the technology? And the second part of the question is where does the data that gives you this internal map come from? Are you coming from MRI, and it's pretty amazing.
Yeah.
I'm just a little curious about the technology.
So to answer your first question, it's an amazing story. The founders of the company that I work with were fighter pilots, Israeli fighter pilots, and they were tasked with, you guys come here. I want you guys to go and figure out a way to make a flight simulator for our pilots. So they were pouring hours and hours away generating, and it actually became a really good flight simulator that they had. It was very reminiscent of flying an actual helicopter. And as they were working together, they were like, this is great and all, but when we're done with our obligatory military service, we should get together and actually help people, not just prepare for war, but maybe help brain surgeons. And it was just, I think it made the most sense to them that they would start with something as complex and 3D as brain surgery. So that's how this all started. And the company I work with is called Surgical Theater, and they are the ones that, it's been a collaborative effort. It's interesting because I'm a brain surgeon. I look at the world through a brain surgeon's eyes, and I can only see the world as best I can through brain surgeon eyes. These geniuses, these engineers, can only see the world through technical eyes. I can't begin to understand where technology is underutilized. They can't always see what matters. Does this matter? It's nice, but it's stupid. For uses in clinics, there needs to be communication. We can't thrive without each other. We have to cross-pollinate, and then when you have that synergy of purpose and tech, that's when really amazing stuff happens. So all the stuff that I'm showing you is like, well, how far can we take this? Can we put it in a 4-year-old? Will they understand the anatomy? Can you share the experience? Can you do X-ray vision? If you don't ask the questions, then you'll never push the envelope forward. So I'll come back.
So can this be, or has this been applied to brain surgeries, but the more routine, like this was like a tumor, but like the people getting VNS or I don't know, even just everyday EEGs, like can this technology be used to help patients understand?
I love that you're asking this question in the Imagineering capital of the world. I love that word, but Imagineering. If you imagine it, it could happen, but you have to imagine it. I think that there are going to be certain things in our surgical world that lend itself so much easier to stuff like this than having a rash and putting a cream on it. You don't need VR, for that. But you mentioned things like VNS. Anytime you have complex anatomy that you just, you're scrolling through these 2D flat black and white images, and you're like, I can't really see it. I can see it, but I can't really see it. Anytime you're in that dilemma, this is where this 3D anatomy technology can come in. And then anytime you're actually going to delve into tissue, it's fantastic to be able to fly around. So it depends on the situation. And certain things are going to be, really easy to apply it to, and then some really hard. I forgot a question before. What kind of images? So basically, CTs, MRIs, with and without contrast. Basically, the prettier 2D picture you give us, the prettier 3D picture we can generate. If you give us if you give us something bland, you're going to get a bland 3D model. If you give us something really detailed, you're going to get a more higher resolution image. And this is a fancy translator. This translates the 2D world to the 3D world.
How good is it at picking up missed lesions or missed?
We don't know. We don't know. But I just showed you some things that either I went back to Jade's pictures and was like, oh, there it is. I couldn't see it before. Or I went back to Jade's pictures and I was like, I'm still not seeing it, But it was there because I saw it in the 3D model and I for sure found it during surgery. So it's going to take years for us to accumulate that kind of data to say, on a screen of 1,000 patients, 70% of them were pathology that wasn't. It's going to take a while.
This is like a 3D syscom. You remember the syscom from data subtraction, imaging,
Yeah. Yeah.
It seems like it's taking that idea
and applying it here. It's a filter of sorts.
But turning it into a 3D version.
Correct. Yeah.
Do you guys have any plans to adding AI or anything to kind of go through?
Definitely. I mean, anytime you have data and repeatable patterns, you teach machines. You have the machine learning component of it, and then you eliminate human beings completely. Are you trying to get rid of?
Something that is like, oh, with all these data and all this information, this is missed with the human eye.
Yeah. I mean, you don't need to be a brain surgeon to realize that this makes total sense. The more cases we have where these patterns come out, the more we should learn from them and do our job better.
For the institutions who adopt this, who do you plan to train to show this to the patients? Would be the veterinary nurse?
Anyone in any. So obviously, the no-brainers. Don't tell my residents and trainees I call them this, by the way. But the no-brainers would be my residents and my medical students and my fellows, the people who were me 15 years ago, who are using textbooks still, or maybe fancy websites to teach them complex three-dimensional anatomy. Well, fine, you can keep doing that, but I can tell you that it wasn't until I was actually operating that sometimes the light bulb will go off and go, oh, that is the three-dimensional relationship between this structure and that structure. Well, why wait until then, till you're under the microscope in some child's brain? You should be using every possible advantage technology-wise to build the building blocks as trainees. But in my operating room, there's a lot of downtime. As I get in the room with the patient, the anesthesiologist needs to get our patient comfortable and sleeping and IVs and setup and all this stuff. So an hour is passing by. So I'm here with my system. I grab my scrub nurse, I grab my circulating nurse, I grab the EEG tech. I'm like, hey, have you ever flown this before? Come here, let's do this. Sometimes the most amazing ideas, have you ever thought of trying to do this, come from the weirdest places. And if you don't give that opportunity for fertile ideas, then you're not helping yourself.
I know some hospitals, I need to educate the patient and train the physician. I know some hospitals have child life specialists.
Yeah.
Especially in pediatrics and inpatient.
Yeah.
So would it be something where you go train the patient? And I know you guys are busy, and the pediatric patients have risen tremendously. So I mean, time-wise and realistically, of course, as most kids as possible.
Yeah, I didn't. This is a very. I'm the brain surgeon guy, So I'm going to give you the VR and AR for brain surgery talk. But one of my side projects is all the non-neurosurgery day-to-day. Wouldn't this be great for kids to be in a hospital and for child life to be using them? And we are. Different kinds of headsets, though. You don't need this, the Bentley of VR headsets to do basic everyday VR stuff. We have other VR headsets that we're using. Maybe to distract them while they're getting minor procedures. Think of all the less opiates that we're having to give now. Think of the kids we don't actually have to intubate and sedate anymore because they're lost in their VR world. I don't know how many of you guys have ever tried to communicate with a child when they're on an iPad, and that's not even immersive. I took a video footage once at my son. He was 5 at the time watching the iPad, and I called his name 10, 12 times, no response. I actually started to knock on his head a little bit, no response. I pushed him, no response. He was sedated, and that's an iPad. That's non-immersive. When you're immersed in this world, and even with headsets plus the AV part of it, you unlock an ability to distract away from pain, and fear. Because those are the two things that you're treating with these IVs is analgesics and anesthetics. You're making them asleep and you're not feeling pain. But if it's something minor, let's use technology. Yeah. But yes, the answer is yes, we're already using it.
Are they using this technology on adults as well?
Yes. Adult neurosurgery, yes.
Yeah.
But the way that I showed you that we're sharing the experience with the kids and the families, you have to talk to the adults about how much they value them being part of the whole experience. It's a lot more business, In the adult world, it's like, do you understand? Any questions? Sign here. Let's move. It's less all-inclusive, and we're a bit more hand-holding in the pediatric world. So I don't know that there's many people doing any shared experience at all in the adult world. All right. Well, unless you guys have any questions, you can come and talk to me afterwards. But thank you. I definitely want you guys to join the experience. Thank you, guys.